journey itself. Hello, everyone. Thanks for joining in today's session. It's so good to see so many people joining in, and you're very excited to learn about this topic as well. And thank you, everyone. Now, before even I go ahead, I would see that so many people may have so many questions in their mind as well about this journey and how they can succeed as well and how they can come to the other side as well. It feels so good to be on the other side. Is there anyone in this group who would like to say few words or anything about themselves, what they are thinking? And then I'll share my journey as well to say how I did it and how you can do it. Is there anyone who has the courage or confidence as well, just to say a few words? I can see so many names: Ying, Sahil, Dr. Sneha, Upadhyay. Is there anyone? Anyways, myself, Dr. Divey, and I was able to clear this journey recently, and I'm a practicing dentist here in Australia. How I did it, it is a journey, I would say. When we say ADC journey, it actually takes everything from you, your time, you know, your relationships as well. Whatever you are going through, there is a lot of pressure inside your brain, and you don't know if you're going to succeed, if you're going to fail. That sort of stress and that sort of mindset always is playing around your brain, and you need that confidence, you need that courage, you need that strength inside you, and that comes with right-minded people, with people who have the right mindset as well. So I met few people just like my wife as well, who have the right mindset to clear the goals, and she helped me as well to clear the exam, the part one as well as the part two as well. So here I am sitting in front of you guys as well. So I do have an experience for about 10 years in the healthcare industry, and the part one journey itself came through the concepts where we were studying together and we cleared the exam in one go. So Dr. Chi is very well equipped with all the concepts. And when we discuss about the cases and the scenarios, that is actually helping me in my journey right now as well. When I see the patients here, especially the Australian population, every single day I find these concepts are so helpful, especially this concept which we are going to read and study today. Every time when I see the case, I can see literally in my brain that we were discussing that scenario and this is in front of me. And that can help me to treat that case, to identify that case, to diagnose that case in more ethical manner and in a right manner. This whole journey is all about the concepts. And right conceptualization comes with right concepts and right mentors as well. So I and Chi have created this Soul ADC platform for you guys only, because we used to help students previously without having any structured approach or any structured platform. Now we thought, like, how about helping you guys or the candidates who have been suffering and they are perplexed about how they can clear the exam. And part one is one of the important steps as well. Okay. Part one is just one step, I'm telling you guys. Part two is one other step which takes everything. It's not easy. I'm not going to scare, but I'm telling you the real truth about this. It takes everything. Is there anybody who would like to speak with me? Or you all are shy? Having 1,000 questions? Anyways, Dr. Chi, do you have anything to say?
Nah, nothing right now. I'm more concerned about people whose exam is just there next month.
Absolutely.
We really want to help you out. If you have any doubts by the end of this session, you can definitely message us. You can definitely reach out to us. Whether you are a member of Soul ADC or not, we are there to help you out, because I understand and we both understand that at the end point, when you say, like, at the end of the journey, when there is no one there, it is very very concerning and very stressful. And we really want to help you out so that you can pass this exam and you can be in the part 2 and then be a dentist here.
Absolutely, absolutely. And I would also like to say one thing. Since the beginning, I wanted to clear this exam by heart. And I did that just because I had the manifestation as well inside my thing. Wherever I was studying, I had this certificate just right in front of my desk, and that helped me too. And it's just a small, recommendation. If you are really wanting to clear this exam, manifest for it, and you will get there. You know, I don't mind. You attend any mentor, us or anyone. I want you to clear this exam with no pressure. Okay? We feel that this is our life. And that's a wrong thing to think, because ADC is not your life, it is part of your life. If you will think that this is your life, it will put burden on you, it will put stress on you to clear that exam in in a way, but still it will put more pressure on you. So just make it as part of your life rather than just your life. Okay?
Okay, so let's start the journey now. Let's start starting the topic. It's already been 8 minutes. I don't want you to wait for a very long time. So March, when I want to appear for it. Definitely, I think Dr. Devi, this is for you. Generally, Dr. Uday wants to know about the how he should do it. Do you want to answer it, or do you want me to answer it?
Absolutely. Look, this is one of the questions I've been answering throughout my journey as well, because I've been getting a lot of Instagram messages and Facebook messages. And there's one of such common questions where people are in their internship period, they get to know about ADC and they would like to clear the exam as well, and they would like to practice in Australia. This is one of the greatest time if you are in your internship period. And if you think about ADC, I think that's the right time. Just because your concepts are so clear at that time when you have gone through the university, you are just building your concepts with the patients, because you are going to see the patients during the internship as well. And when you take the mentorship during that period, I think you just need 4 to 5 months of time. A clear mindset brings up your life to the level where you can clear the exam in a smooth manner without having multiple attempts. I think, Dr. Kumar, if you will start preparing from now onwards while focusing on your internship for sure, I do not want you to just ignore your internship, because internship is a solid foundation before you practice onto the patient. So focus on that, but the remaining time, at least 2 hours or 2.5 hours in a day, where we also offer, recorded lectures, and you can watch those lectures in your ease time and prepare yourself for the exam. So part one you can book in for the March, and there you can prepare it during the time of the internship, after the internship hours, and when you complete the internship, you can sit for the part one exam as well. I hope I was able to answer you, and if you have any doubt, definitely we can talk more about this. You can unmute yourself if you like, or you can type in the message box as well.
Yes, sir. Actually, now I'm currently doing my internship.
Okay.
From
India. So, how far are you in the
I'm
internship?
Planning for. Yes, sir. So I'm planning to do that ADC part 1 by next year.
Yes.
September month.
Okay.
So I don't know how to start, and yeah.
Okay, so have you already done the initial assessment part of the?
No, sir. No.
Okay. Now the beginning is through the initial assessment, and once you get the initial assessment, your degrees needs to get assessed as well. So once, I think you might also need to submit your internship certificate as well. So which is why I was asking you, how far are you from doing your internship? So once you complete your internship period, you will get an internship certificate as well, and you can submit that letter.
Still 6 months to go, sir. Yeah, actually, still 6 months to go to complete my internship. So after that, I want to go for initial assessment. Then I want to appear for ADC Part 1. Right, sir?
Absolutely, absolutely. Look, the exam itself don't stop you from preparing.
Okay.
All right? That's the line. If you understand this thing, you are preparing yourself in these many months, so you have a bonus. So if you start preparing now, and you are preparing for your documents as well, I think there is no one who can stop you in clearing this exam in one go, because you are at the spot where you are seeing the patient, you are fitting your concepts there and wherever you are, and from there, when you go for the part 1 and you see these multiple choice questions where you feel that all the questions have the answers to be marked as, like, I can mark this one, this one, this one, but when you go and mark it with the right concept, there is no one who can stop you from marking the right answer.
And to be honest,
start preparing now.
And to be honest, Dr. Kumar, we do not prefer you memorizing things. We more prefer that you understand the concepts and you are able to use the logic, because Dr. Divey is able to use all the concepts here. He has seen tons of patients with abscess. You talk about tooth wear, you talk about fractures. There are things. He comes back home and he shows me the picture. See, I saw this today. See, that's the concept we did in part 2. We did it in part 1. So these concepts are really intriguing to see. And to be honest, that's the best time to start preparing, because when you're doing the internship, you see the patient, you use it, you use your brain, plus you have ample amount of time to study. Once you start working, things become little trickier, and I don't want you to be at a back position when you don't have time. We put our effort, but we want you to put your effort as well.
And before we go ahead and answer all the questions, I can see one more question popped up in the chat, but I think it will take a lot more time to discuss about the topic as well, which is one of the important topics. And I think let's begin the topic. And in the remaining time, in the end of the session, we will, answer all the questions as well. I think the dental suite, is it all right for you as well if we, answer your question as well in the end of the session?
And we'll definitely answer it. Don't worry about it. Perfect.
Fantastic. I think.
Thank you, ma'am.
Let's start by understanding the concepts, and you will definitely enjoy the whole session as well. And I really want you to take the concepts from here and put that with your patients as well. And you will see the difference, because we are going to discuss about the treatment and the management and the concepts. All right, I'll leave that with Dr. Chi, who is the specialist in it.
Specialist in teaching only. Okay, let's begin today then. And if you have any doubts at the very end, ask us. You can also message us at the end, any day, any time. It's okay. We'll answer you. We'll help you to find out the answer also if you have any doubt with any question regarding tooth wear. But in your exam, I want you to clear this concept and go there and mark the correct answer. No wrong answers in this one. Okay? So let's go ahead. I'm going to explain you what tooth wear is. Now, we generally know what wearing is. Wearing of the tooth. Basically, you see there are different patterns on the surfaces of the tooth. This is basically of different types. One is attrition, abrasion, abfraction, erosion. So what is this? It's basically a cyclic process that we are doing. We are, for example, I'll just tell you that if you are a lot in stress, you start grinding your teeth. Grinding, clenching is basically when you do it at night, or you can do it at during the day as well, like bruxism. Okay? And what does bruxism do? It causes wearing of your tooth. Your tooth wear can be physiological as well as pathological in nature. What I'm saying is either it could be age related, or it could be just a normal process because you are doing some clenching, grinding during the day or night. Okay, so what do we see? We need to identify what is the back story of it. If you are able to sort out what the backstory is, if there is stress, if there's anxiety, we are able to solve it. We might be able to reduce the thing that is happening. Okay, so the first thing is attrition. Now, what does attrition mean? Attrition means that your teeth to teeth come, tooth to tooth coming into contact, and they causing the effect on the incisal or the occlusal surfaces. But why does this happen? This generally happens because of, like, you are doing some habits like bruxism, okay, clenching, grinding for a very long time. So these all causes flattening of the edges of the occlusal or the incisal surfaces, and can also lead to dentine exposure. I'm going to show you pictures from the next slide as well. So we'll understand this and then we'll see pictures. Okay. So attrition, what does that mean is basically your teeth are moving, and that is causing reduction in the level of the surface of your tooth. Okay. Now, when I say attrition, I am saying about this area mostly. Okay. However, when I'm talking about abrasion, I'm talking about this area, the cervical area of the tooth. Now, your cervical area, your CEJ area is very thin, and when there is too much of force applied, abrasion, abfractions can be observed there. Now, what is abrasion? Frictional force on the tooth due to exogenous objects. Now, what is exogenous object I'm talking about? Like a toothbrush. So, a patient doing too much aggressively brushing on the teeth, that can cause abrasion to happen in this area, in the cervical area. Okay. So toothbrushing or biting on the hard surfaces such as pens, pencils, hairpins, all these can lead to abrasion. Now, we also say that ceramic is a type of, we put some permanent restorations like ceramics on the surface of the tooth. Now, when we are putting ceramic crowns, if they are unpolished, they are the highest level of the thing that causes abrasion. Okay. So we have to be aware that if we are giving ceramic crowns to a patient, they should be smooth, polished. Okay. Generally, that will be done by the lab, but you have to be aware that they are smooth and they are not rough, because when they contact with the teeth, they can cause abrasion because there's too much of force and too much of problems becoming because of that. Now, when I say abfraction, similar to abrasion, they happen on this surface, but they will be more like a notch type, a wedge type. Now, if you have seen wedges, wooden wedges in your universities or clinics, exactly like that shape, like a triangle, it happens on the cervical area. So if I make you the tooth, so this is the buccal, or I can say the palatal surface, suppose. So like this. If the lesion happens like that, that's abfraction. So it's a V-shaped lesion at the cervical margin of the teeth, subjected to excessive tensile stress during grinding movement. Yes, we will be showing you all the pictures. Don't worry about that. It's from the next slide. I'm just going to explain you the concept here, and then we'll show you pictures. Don't worry about that. Okay. So abfraction here, and your abrasion also happens in this area. Now, when it is too much like a wedge shaped, it is abfraction. And when it's just a little bit, you see any defect happening, that is your abrasion. Okay. And when I say erosion, like a person have some gastric issue, so gastroesophageal disease, that is GORD or GERD that we say. These conditions is basically, it's an acid coming from your stomach that comes and causes erosion in your mouth. Not only that, if a person is drinking Coca-Cola or any drinks which is acidic, even fruit juices like orange juice, lemon juice, a person getting up in the morning and drinking a warm water with lemon in it, it's an acid that you are providing on the surface of the tooth. And these all causes erosion, that causes the layer of the tooth to get out. It becomes soft. The outer layer becomes soft. That is your enamel. and the dentine starts getting exposed. Okay, so it's a non-bacterial acid demineralized enamel and dentine hydroxyapatite surfaces. It basically what it does, it softens due to loss of calcium and phosphate ions. So basically your calcium and the phosphates are getting removed from the surface of the tooth. Now what are the clinical features? If I talk about your intrinsic erosion, now just imagine if an acid is coming from inside to outside towards your mouth, what are the surfaces which becomes more exposed? It will be more of your palatal surfaces of the tooth. Okay, so your palatal will be exposed if we are talking about from inside, and when we are talking about from outside, it's basically the incisal edges, the buccal surfaces of the tooth that will be more affected. Now when I talk about which is the surface least affected by erosion, that will be your mandibular incisors on the lingual side. Why? Because we have your submandibular and sublingual salivary glands. They open up. In that area, we have saliva too much in that area. We have tongue which protects that. That's why on the lingual surface of your mandibular teeth, they will be least affected. Now, so basically in erosion, when we talk about how the lesion looks like, what basically happens? There is cupped out appearance in the early stages, and in the late stages what happens, it's crater like appearance on the surface of the tooth. I'll show you the pictures. We'll go slowly one by one with all the concepts, so don't worry about that. Okay, so in early stage we see cupped out lesion. In the later stage we see crater like appearance. Now if you see here, this is attrition. So patient is grinding too much. That has also caused cracks, crazed lines to develop on the surface of the tooth. These are how the lesions look like. So it is attrited. It's like a flat thing that is happening. If you see in this one, this is basically here that has started to happen. It is more on the incisal area rather than happening on the other teeth. Okay. Now if you see in this one, how you see the your lower incisors and your in fact your canines as well, how they have flattened up. That's your attrition. Now if you see here, what is this? This is abrasion and abfraction lesions that we are talking about here. Now if you see here how they look like, that's your abrasion that is happening, and this one is your abfraction. See how deep this goes inside. It's like a steep thing going inside. That's your abfraction. It's basically how bad it is. If it is just a little bit, that's your abrasion. If you see like a wedge shaped, that's your abfraction. Okay. And if you see here, this is basically your cervical and proximal abrasions, which is because of the oral hygiene technique. Okay. Now, if you see here, you also see here, based on the clinical appearance, you can say is it abrasion or abfraction. Okay. More on the cervical areas. You can also see if the roots are exposed, they can also have such signs as well. Okay. Now, if you see this one and this one, this is like you say a cupped appearance. It's like a cup sort of notches formed, and you can actually drink coffee in it. So it's like cups. Okay. And this is like a crater like, too much of reduction on the surface of the tooth. Okay. This is also your erosion. So in erosion, you'll see some translucency and the yellow dentine starts getting exposed and they start appearing when you see clinically. Okay. So that's how it looks like. Now this, if you see, this is because of your GERD. Okay. Now important part for you to know is your anterior teeth, where generally is mostly observed. Once, because we have canine guidance. Once your canines gets destroyed, then we'll see your posterior teeth starts getting affected. Now, there are certain cases where we'll see the posterior wear first. We'll see the posterior teeth causing the problem, and those are in your class 2 Div 1, your class 3 malocclusion, and when a patient has anterior open bite. Just imagine your mouth is open, okay? Your back teeth are colliding, they are in contact with each other. Once they are in contact with each other, what happens is a person is grinding, and that causes the wear of the tooth, okay? So that's how this happens. However, generally it's the anterior teeth which gets affected the most. Okay, then we have different type of classification. We have BEWE, we have Turners. You can Google it, you can read about what basically they are. There are different types. Your BEWE is similar to your BPE. It looks at 4 surfaces of the tooth, and it's been really hard there's been a lot of research, and there are both the sides that which type of basically your tooth wear classification and things are better. But I will leave few things for you to read as well. Go through it, how it looks like. Okay, what is BEWE, what is Turner's classification. These things are just for you to know as well. So now coming on to the physical markers of tooth wear. Now, when I say physical markers, what do we see when a patient is having tooth wear? There can be hypertrophic masseter. Basically, we have a masseter muscle here. So what happens is you will see like this. There's stiffening when you touch to the on the face of the patient. You will see some stiffness observed. You will see patient might feel some pain in that area. These are some physical markers, or basically the information that you can get regarding the tooth wear. There will be patient is either clenching, grinding, or what can happen with that is you can see some buccal keratosis. When I say the word keratosis, always remember there's something white we are talking about. Okay, so cheek biting. So these are basically the lines that you can see. It can happen on both the sides of your buccal mucosa, and these things worsens up when there is dryness as well. Now there can be scalloping of the tongue as well. There can be loss of canine guidance. Your canine starts getting flattened as well. There is loss of canine guidance. There is shortening dental arch over the 15 years period. We can't say by just today that patient is having wearing and tearing of the teeth. There is tooth wear. We have to observe over a period of time. Okay, these lesions do not develop in a single day. It takes a lot of time to develop. So these are wear facets that we are talking about, that we can see on the teeth clinically in the patient's mouth. Okay. Now coming on to some markers. Now there are different reasons why a patient can have these problems. We say there could be different reasons why they are having. But we have observed that patients with genetic conditions like amelogenesis imperfecta, they might have there can be some erosion which can be observed in these patients as well, because their enamel is quite weak. Okay, now when I talk about pain, patients sometimes they might have pain observed on their facial area. So basically when the patient comes to you, you generally ask them, is there a TMJ problem? Okay, that is one thing. The other thing is, do they have pain in the muscles here, or they have headache? These are the markers that can help us in identifying these problems. Now when I say psychology, it's been observed that patients with ADHD, they might have this problem, anxiety, mood problems. Basically these are the patients who might be bruxising, and if they are bruxising, we can see some things happening in the mouth. There can be attrition observed in the mouth. Okay, low saliva, it's been observed, it's been said that it is one of the factor that in which you will see tooth wear. Erosion, in fact, if you talk about erosion, it gets aggravated when there is lack of saliva, because saliva is a barrier. It helps in swishing around all the acids from the mouth. If the saliva is not there as a protector, what happens is it further causes deterioration. Okay. Now there are some conditions like Sjogren syndrome. Definitely there will be low saliva. there is going to be xerostomia in the patient that can be affecting. Now, the other is sleep disorders. It is observed that people with sleep apnea, they have problem in breathing. Sometimes they snore at night. They have the constriction of the jaw is there, and that can also aggravate bruxism in them. Now, some stomach acid, regurgitation, we were talking about, GERD. GERD is a condition where there will be the acids coming inside the mouth. There are other conditions like anorexia, there could be bulimia. These are certain conditions where patient does have the problem of wear as well. Now, when I say anorexia, what is anorexia? Anorexia is a condition where patient does not have overweight. Their BMI might be fine, but still what they do is they purge out what they have eaten. So either by using laxatives or by just inducing vomiting. When I say bulimia, they are people who eat a lot of food and then they take it out. So these patients might be suffering from psychological conditions, and that's why they might be throwing things out, and that causes the acid, your stomach acid to come out and cause problem in the teeth. Okay. Then when I talk about social markers of tooth wear, generally you will see in your TG as well. If you read bruxism, you will see alcohol abuse, smoking, drinking coffee, especially after 4 p.m., having erosive diet, having recreational drugs like ice, that is methamphetamine. These all can aggravate the problem, and these all can cause the problem as well. Okay. Now, causes of erosion, if I talk about, as I was talking about GERD, there could be, these are intrinsic causes, these are extrinsic causes. So basically, what are intrinsic causes? The ones which are from inside, from your body. Your dehydration is also a part of it. And as I discussed, anorexia, bulimia, chronic alcoholism as well. Rumination is basically person, as in it's very yucky to even think about it. People actually puke, not puke, basically their content comes into the mouth and then they just swallow it or they just chew it back. Okay. So these are all the factors. That's basically your stomach acid is coming out and that's causing problem. When I talk about your extrinsic cause, we have carbonated drinks, we have fruit juices, smoothies, occupational hazards. Then we have vitamin drinks. In fact, there are some small tablets that comes in Australia, which is vitamin C tablets. And in fact, there are other types of tablets as well. They are available easily, which you put it in the water and it causes it has acid in it and it causes extrinsic erosion. Then sports such as swimming, there's been a research and they can say that there is the pH, or basically there is something with the swimming water that causes erosion on the surface of the teeth. Extrinsic cause of that is there observed. Okay. Now, acid is considered the main cause. Progression is also accelerated by mechanical factors such as attrition and or abrasion. Now, it is observed that your anorexia, it is more observed in the age group of 13 to 18 years of age. And your, if we talk about bulimia, it is in the age group of 16 to 17 years of age. Now, binge eating disorders. Basically, it's more observed that people eat a lot of food for a very longer period of time. More observed in males as compared to females. Pica is also a condition where people generally take non-nutritive eating substance like soil, sand, bricks, these sort of things they can eat, even chalk. Maybe in your childhood you might have taken it. So it is for at least a month. In pregnant women it is seen, in children, and what it causes is, it causes attrition on the surface of the tooth. Okay. Bulimia, at least one episode of binge eating per week, followed by compensatory behavior that includes self-induced vomiting and misuse of laxative or diuretics is basically what we say bulimia. Okay, so if you see here, this is in a GERD patient. Acid, basically there's acid in the mouth and causes how you see how the surfaces look like. Okay, now coming on to evaluation. Now I've already mentioned you how we evaluate, right? There are signs that we observe that we discussed here, the physical markers of the tooth wear. That's how we observe and that's how we know what basically is happening. But when the patient is here, we need to evaluate. We are dentists. We need to see everything. We need to see if the tooth is fine. Is there any sensitivity patient is having? Is the patient is having some, TMD problem because of grinding? Any trismus happening, or do they have pulpal involvement, any sensitivity happening or pain happening? Okay, so we need to do your endodontic evaluation as well. So we check the vitality of the tooth by using a cold test or an EP. EPT is electric pulp testing. Okay, your endodontic evaluation, we are saying periapical x-ray also is required. Okay, why do we need x-rays? Because we need to see what is happening down there. Is there any problem happening? Sometimes what happens is there can be vertical root fracture. If there is vertical root fracture, what do we observe in an x-ray? We might see a J-shape radiolucency in this area, J-shape. And it's not always available in your x-rays. That's not the best thing to tell us. But we still take x-rays to see if there's any problem happening underneath. So how we will come to know is by using a probe. We go around the surface, basically around the tooth, and any point it goes deep down. Maybe there is a pocket depth of 8 to 9 mm only at one spot. That means there could be a vertical root fracture. Okay, so what are we looking at? Endo evaluation. We are looking at your x-rays as well. We are looking at your TMD. We are doing full periodontal examination. As I said, we need to check if there is any probe going very deep into one particular spot. Rarely chronic perio conditions and tooth wear are seen together. In fact, rarely decays as well as your erosion seen on the same tooth. Why? Because there's acid, it removes everything. Okay, it gives a luster, it's there. But generally for your tooth wear to happen, your bacteria needs to sit there and cause destruction for a very long time. Okay, so that's why we generally do not see your perio, your erosion or your tooth wear going side by side along with that. And if we are evaluating the patient, how do we evaluate or how do we observe, how do we say over a period of time that patient is having any tooth wear? We see, we take impressions of the patient, we make cast, we also put it on the articulator as well. So that's why we take cast, we take impressions for the patient. However, we need to see patient's vertical dimension. Generally what happens is, if a patient is biting down for a longer time, they are grinding, their vertical height of the face gets reduced. If you remember, there is something called VDO or OVD, that's vertical dimension of occlusion. That can be lost when a patient is grinding, clenching for a longer time. Okay, so if a person is grinding, these things are happening. What can happen is, there can be loss in the vertical height, there can be angular cheilitis that you see, that can happen, there can be wrinkles formation. Now what is angular cheilitis? There is inflammation happening in this area and your bacteria, fungus basically comes and sits into this position and causes redness in this area. Okay, so these are few things that we observe, and over a period of time, when a person comes today, we'll take impressions, we keep study cast, we take impressions, and when we make study cast or we take scans for the patient, we are going to evaluate as well, and we see if there's any change in the tooth. Okay, so if the teeth have been treated, what basically is happening or not, that can be observed by that. So how do we check the progression of teeth wear? By study cast, your silicone index, and intraoral scanning or sequential records can be observed. Okay, now this is basically a decision chart that we are talking about. There is how we understand basically what needs to be done. Now, when I say pathological and when I say physiological. Now, what is physiological? Physiological means when a person is growing with age, as the age is progressing, the things start changing. Your teeth starts wear and tear a little bit. If there is physiological reason of tooth wear, no treatment is required. Okay. If there is no physiological, we are talking about pathological, then we need to see what we need to do. Okay. Can you please mute yourself? Dr. Santosh, can you please mute yourself? Thank you so much. We'll complete everything. We'll take up the questions or whatever we'll discuss at the very end so that we are able to complete everything on time. We only have limited time left and I really want to complete everything for you. So when I talk about pathological, I am saying you're grinding, clenching, bruxising, all these things are happening. So we need to cater that. We need to sort that out properly. Okay? And how do we do it? First, we need to identify what is the cause of it. Is there a person having stress because of that is happening? Or what basically is happening? Are they taking coffee at night? They are taking alcohol at night that is causing aggravating and causing your CNS to actually cause problem. Okay, so we identify it, we counsel as well as we monitor the patient. Okay, if suppose we are able to, when you see that if that's the problem, we need to understand that we need to cater it, we need to solve it out. Once these things are done, we also need to do one more thing. That is, we take a consent and we do restorative interventions. Why do we do restorative intervention? Is because if there is a wear, your dentine is exposed, patient will be having sensitivity. Now, if you leave it like that, is it a good thing to leave it as it is? Is it good for the patient to have pain or having sensitivity for a longer time? Definitely not. We need to help the patient out. Yes? That's the acute care that you provide. So that's why we need to do the filling. And why do we need to do? Another reason is we do not want the pulp to get exposed. We do not want pain to develop in the patient in a longer time. That's why we need to do fillings. So active restorative intervention is necessary where there is significant area of exposed dentine, where there is risk of tooth fracture, and if there is hypersensitivity which cannot be controlled by any other means. What are the any other means? Counseling, monitoring. Obviously, we can't control with that. And in fact, we'll be doing preventative advice as well to the patient. We'll discuss on the preventative advice. Don't worry about it. So we tell patient what needs to be done, what we are suggesting them as well, because it's not a single approach that we'll do the filling. There are many things which are involved with that. So what are the preventative advice that we give to the patient? One is counseling and monitoring. That's the choice of treatment for moderate to severe tooth wear. That's the first thing that we start doing. Okay. After that, or apart from that, what else is required? We need to give them Michigan splint. This is basically a hard splint given on the upper part of your teeth. So basically it is giving on the anterior. On the upper teeth. If we are going on the on your lower teeth, it's called a Tanner splint. Okay, it is advised for patient. Basically, it's a splint, hard splint that is given, and it prevents further destruction of the teeth. So you are going to do the fillings, right? But you need to also give this preventative advice. Ask them to get this, so that no further destruction happens. The restoration should not break, the teeth should not break further. Okay. Now, when we talk about patient with GERD, what can happen is the material, the acid can go inside the splint, because sometimes with erosion, there can be attrition as well. There could be abfraction or anything else happening as well. Mainly attrition that can be seen with these patients. So that's why if we are giving, that can be also, we need to be aware and we need to provide awareness to the patient on that. Okay, so sorry. That's what I wanted to show. So splints may be used to protect teeth during episodes of vomiting for the bulimic patients as well, which are worn during the vomiting period only, and after vomiting should be removed and cleaned. Again, precautions and instructions need to be given to the patient definitely about that. Okay. Now we also say healthy eating, good oral hygiene needs to be maintained. One thing is, you drink like Scooby with a straw. Okay. Why? Because as less surface is exposed, less chances of erosion happening. Okay. And we always say patient to switch some water after it, so that water can actually remove the acid from the teeth, from the surface of the teeth. Using a straw, do not brush for 1 hour till the you are exposed to any acidic drinking. Okay, do not swish around the beverages in the mouth. That is required, that we should follow, and do not sip for a very long time. Now there's been a question in the past as well. The best thing to do is beverages should be limited to meal if they can do it, so that it's basically, we are talking about the frequency of exposure. As frequent they are, if you remember your Stephen curve, or if you know about your pH, it drops down below 5.5. Once the pH drops down below 5.5, your demineralization starts happening, and our mouth needs around 2 hours to recover back. Our saliva needs 2 hours to recover back. If we are not giving appropriate time, what can happen is further problem can happen, further deterioration can happen. Okay, so we want them to take the beverages during the period of when they are eating meals. Okay, when they are with that, it's better, it is more preserved. Okay, now if a person is having erosion, we generally recommend them to have toothpaste with fluoride. Preferred is stannous fluoride. There are others as well. There is your sodium fluoride. We have CPP ACP, that's your casein phosphate, phosphopeptide amorphous calcium phosphate. This is basically your tooth mousse. Tooth mousse is basically, this much tube that comes in Australia. People do recommend it to people. The good thing is it provides your calcium and phosphate ions to the surface of the tooth, so helps in initial, if there's initial caries or initial incipient caries, if you observe, it helps in remineralizing and improving the teeth as well. Okay, so they are also good for erosion patient. We can give it to them. We can give stannous fluoride to them. We can give calcium silicate. All these toothpaste can be used. These are remineralizing agents. Okay. Now when I talk about management, patient has problem in the mouth. Attrition, abrasion, erosion, abfraction, anything, we need to correct it. Okay. So what do? There are different options. What we can do is, we can do restorations. We can put filling material on the top, for example, composite. We can do fixed prosthesis. Now, if suppose the teeth have been abraded completely, if suppose only this amount of tooth surface is left behind, what we will do? We can give overdentures. That's one of the thing to be done, right? There is something called full mouth rehabilitation. What does full mouth rehab means? Your video needs to be corrected. There are a few things we need to consider as well. I'm going to explain you. Don't worry about that. So fixed prosthesis is an option. We have orthodontic extrusion. We have crown lengthening. Now what is orthodontic extrusion? We basically use ortho. We can use TAD. TADs are basically small devices. We put it on here, like they can be placed here, can help in the movement of the teeth. We can use other things as well for the movement of the teeth as well. And with the ortho extrusion, what happens is basically your teeth will start moving, and it improves the bite. I'll explain the DAL concept Basically, everything solves by when I explained you that. Okay, so we have this crown lengthening is basically you are cutting some part of your basically some part of your gingival zenith and all, and then when you cut a little bit, your clinical crown appears longer. Okay, so these are some options which are available. So these are some things that we do. Now, the main concept comes here is Dahl's principle. Now, what is Dahl's principle? When I say Dahl's principle, it's basically a person who gave this concept, who said what happens is if these are your anterior teeth, these are your back teeth. Okay, what we want is we want to raise the bite. Basically, the video has been reduced for the patient. So if you put, suppose, just imagine I put something on the occlusal surface of your posterior teeth. Are you going to feel comfortable? Definitely not. You will feel there's something sticking on there and it is bothering me, it is impacting me a lot. So how do you manage it? How will you put filling on the surfaces of the tooth if they are retreated? Because if they're retreated over a period of time, patient will become comfortable with it and they will have reduced height of their face. Fissuring is happening, problem is happening, they are having so much of issues. If we want to manage that, we need to go step by step. We need to sort one thing out and then we can put the filling. That's what the Dahl principle is. They ask us to put something here, maybe on the palatal surface, could be, I'll give you an example. This was what the Dahl appliance supposed to be, where basically there used to be an appliance placed into this area and that used to be metal. Okay, so Dahl appliance is basically a metal thing that we are putting it, and that causes the raise of your back teeth. So they don't collide with each other, and once the gap is created, then later on you put the filling. Okay, so Dahl's principle is more like you disocclude your posterior teeth by putting an appliance in the mouth, and then once they disocclude, your back teeth starts extruding out. So they start erupting out, and once they start erupting out, they will bite into a different position. Now once they bite on a different position, you have ample amount of space in your mouth, and then when you put the filling, they are not going to cause problem to the patient. Okay, so that's how we are increasing the vertical dimension for the patient. Okay, so we are more working on the anterior teeth first. They disocclude, and then what we do is we see the teeth slowly starts moving it. So it's a very slow process that happens over a period of time. It all depends on the patient. Sometimes it can take 3 months, it can take 6 months, it can take a longer time as well. And once they become into a new occlusal position, then we start with the filling process. Okay, so this is another appliance. If you see here, this is the new type of the appliance that we use. Instead of Dahl appliance, which used to be very hard metal one, we use anterior biting planes, basically where your back teeth, if you see, they are not covered. So they will move because there is space. So they will say, okay, there is a lot of space now, let's move into the position, and they'll start occluding into the new position. You have gap. If you see here, this is basically a thick material here in this area, and later on we remove. This is a removal appliance. So when they remove it later on, there will be a new bite. So there are two ways. Either you give an appliance like that, or you put some injectable composite for some time and the bite changes. Okay. Now coming on to the restorative method, what basically we are doing. If you are looking at the restoration, please remember this slide. It is very important for us to know about it. Active restoration interventions is really necessary for us where there are significant areas of exposed dentine. Because if the dentine is there, sensitivity is there. We as a dentist, for us, it is really important that we do something which is beneficial for the patient. We help the patients out. We do acute care. That's why we are going to put filling on the top. Okay. Where there is risk of tooth fracture, there also we do the restoration. If there is hypersensitivity which cannot be controlled by other means, then also we are doing it. Okay. I want you to take the screenshot of this slide.
Hi, Dr. Chi, we can't hear you.
Okay, since when is that a problem? Okay, since when you can't hear me?
Just last 2 lines, I think.
This slide was fine, the previous one?
Yeah.
Okay, so I'm just going to repeat what I discussed here. So when I say restorative, I am talking about I want to provide acute care to the patient. Can you hear me? Please send.
Okay, yes, you're audible now.
Perfect. Okay, so what I am saying is why restorative I'm doing is I am giving an acute care to the patient because patient is here. Patient can have exposed dentine. There can be pain. Basically, sensitivity can be there. Okay. So I need to take care of the sensitivity that the patient is having. So I am giving some restoration. In fact, if a patient has a chance of having tooth fracture, then also needs to be done. Okay. So tooth is weak, restoration is required. Hypersensitivity, which cannot be controlled by other means, the preventative advice, if it was mild, it might not be effective in very severe cases which is happening, or there is sensitivity, there is pain happening in the patient's mouth. We need to do something. So as I said, we need to prevent pulpal exposure for a longer period. Okay. Now, I want you to take a picture of this slide because it's important. If you have questions in the exam, you can select the correct answer. Okay. So if I say root surface filling, if there's an abrasion, abfraction happening, what you will put? GIC. Okay. You can also put composite, no issue with that. But when we talk about your root surface, if you are not able to isolate it, it's better to put GIC. Okay. When I talk about your palatal surface, the best material of choice is gold. Now there are different types of gold. There is type 1, type 2, type 3, type 4 gold. Type 3, so basically 1 means soft one, 4 means hard. It's based on the hard and softness. It's been divided into 1, 2, 3, 4. So when you are putting gold restorations for your patients with tooth wear, we are looking at 3 or 4. Okay. So there is no direct adhesive for palatal. Basically we are not doing anything. Basically what we put is gold that will be done. Not direct means we are not building up. So there are 2 types of restoration. One is direct and the other is indirect. What is direct? That we make it in the clinic. What does indirect means? That we are asking the lab to make it. So when the lab is preparing it, the strength will be more. Okay. And which one we are preferring for this? We are saying gold is better. There are non-precious metals as well that can be used like cobalt, chromium, nickel, titanium, nickel, chromium. These all are some materials that can be used. But the best one is your gold, that is recommended one. Okay. Whether it be on the posterior or on your anterior. Now you must be thinking with that also that if I'm putting it on the interior, that's the aesthetic zone, right? I am talking about on the palatal surface. Okay. And then it is easy to mask. Now there are 2 things. If you see gold on the back, just imagine gold and you have a surface on the top. And you have black or silver color at the back and a surface on the top. If you are able to see, if it's basically gold color, how do I say? If you have any gold sheet and you put a cotton cloth on the top, which one will look more aesthetic? Gold or the silver one? Anyone wants to answer? Gold will look better when you see from the cloth or the silver? No one? Are you able to understand what I'm saying? Thumbs up, thumbs down. Guys, please reply so that I know. Yes?
Gold.
Gold best. Good answer. So gold looks good, whereas when we say silver, it will look bad. It will look like there's something wrong going on, right? So that's why on the palatal surface we are talking about putting gold. Okay, so that is strong as well as it is more aesthetic as compared to your silver when we see from the front. But we are going to hide it as well. Okay, the palatal surface is not visible, but the incisal surface we are putting composite on the top of it. Okay, so we do metal and we lute with opaque cement. So we'll put composite on this surface. I'll show you in the next slide how it looks like. Okay, so let's go on. Let's continue with it, and then I'll show you pictures as well. So don't worry about that as well. Now, only affected enamel, we put composite resin. If there is cervical dentine exposure, what do? Is first we blast the surface with aluminium oxide. So basically there is a thin tube like you will see in your clinic as well. There's some sandblasting, we generally say like that. Okay, so that's basically your aluminium oxide. 50 micrometer I believe is the size of the particles that we use, and we blast it on the surface. On this surface we'll first blast it and then we'll bond the composite to it. So better retention, better strength will be there because it will bond properly. Okay, if we do not blast it, there is a possibility that it might not bind it and it might chip off later on. There's been, I believe, a question in March. So please remember aluminium oxide under a pressure of 30 to 45 psi. Okay, when I talk about your back teeth, when we are talking about your back teeth, your metal will be better. Why? Because there's too much of pressure. You are grinding, clenching, that's one thing. Plus your teeth, there are normal functional habits that you're doing. You're eating food from your back teeth, right? So they need to be very strong. So what do we put? Gold or non-precious metals like nickel chromium or cobalt chromium. Best is always going to be gold. So if you have 4 options, composite, nickel chromium, gold, or you have inlays. In fact, even inlays are mentioned. You'll always select gold crowns. That's going to be the best answer. Okay. Now, ceramic veneers only were where low occlusal load is there. So if you're talking about premolars, we can give ceramic veneers. Zirconia, lithium, these are some options. Okay, so Emax that you use in your clinics, they are your lithium disilicate. Okay, they are not preferred for your molars. The best is always gold. Composite resin, direct or indirect. Now you know what is direct and what is indirect. So composite resins or ceramic to restore large areas of multiple occlusal surface should be avoided. Okay. Now porcelains and composite resins can only be given if immediate disocclusion of the posterior teeth is there. Now what do I mean is when you are biting, if your teeth at the back are not meeting, there are less chances that they are going to break down, right? So how do we prevent it? By giving splints. If the patient is wearing splint, they are not biting together, they are not going to chip quickly. So then porcelains and composites can be given. Rest, gold is always the best. So this is how I was talking about. Gold can be given at the back. This is how it will look like. And then you will put some composite. In the clinic you can do it. So this is your rubber dam. You have isolated your teeth. So when you isolate it, you are able to do the work properly without saliva interacting and causing problem. Because always remember, composite filling, where you can't do composite, where you cannot isolate. According to Australia, I don't care what you do in your home country, but in Australia, composite equal to rubber dam. If you do not isolate, in the places where you cannot isolate, you cannot put composites. Okay? Always remember this concept, because if you have any question like that, You should know where you cannot put composite. And if you cannot put composite, what can you put? You have GIC, you have RMGIC. There are these materials that can be placed. So you isolate it, you put your, so basically this is made from by the lab. So they are indirect restorations. And then you put composite on the top and you increase the height. So see, the height was here, now the height is here. That's how you do the fillings. And this is type 3 gold alloy. Now, as I was saying, there is type 1, type 2, type 3 and type 4. You can go Google it, read about it. Okay. So type 4 is the strongest, type 1 is the weakest. So for these patient, tooth wear patient, 3 or 4 is what we can give. Okay. This is type 3 gold, type 3 gold. Okay. Now, then let's talk about splints. So we have splints. There are different types of splints available in the market. We have partial splints, we have full splints. We do not recommend partial splints because patient can engulf as well. Okay, so they are not recommended anymore. But there are other like Gelb's appliance. If you see, this is the Gelb's appliance. What happens with that is it can cause some problem. It can cause supra-eruption of your incisors and canines and intrusion of the posterior teeth. As per your DIALS your concept, we want your posterior teeth to come out, to extrude. Okay, not your posterior teeth to intrude. I hope you're getting this. Any issue with this? Any issue with this concept? If you have any issue with the concept of DAL, please tell me. You will see this concept in your exam. Yes or no? Anything? No, doc, all good? Perfect. Okay. So, if you have any doubt after this session, message me. I'll explain you again with the DAL concept if you have, or I can send you some reference, or you can Google also and see what basically DAL concept is. Basically, you need to disocclude your back teeth. They should not come in contact, so that when they do not come in contact, they say there is space, they start moving and they come in contact. They are like this, they come here like this, and once they come like that, you have space now created in your mouth, and then you build up. So that was just a repeat on DAL's concept. So we don't give Gelb's appliance. DAL appliance creates extrusion of posterior teeth. Now, if we talk about your full arch splints, we are talking about Michigan splint, which is stabilizing the condition. It is preventing further destruction to happen. Okay, that's why it is called stabilizing splint. Then there is anterior-posterior repositioning splints. There are sometimes we might give these type of splints as well. Repositioning splints, which will help in reposition the mandible into a predetermined position, the position which is okay, which is good, because sometimes your positioning might be incorrect and that can cause further attrition. Now, if you remember, I discussed here, where was that? I discussed class 3 malocclusion. I discussed anterior open bite. Class 2 div 1. These were the patients who can have posterior shortening of the teeth. Okay, generally more will be anterior. So if they have this problem, if they are having this, they might require a repositioning splint as well. Okay, so these are the splints that we need to know. Now, there's been a question from bruxism in youngsters as well. So though bruxism causes tooth wear, that should be out from our topic, but I wanted to discuss this as well so that you can solve all the questions regarding your tooth wear. Okay, so bruxism, when I talk about youngsters, we are talking about children and adolescents, and they can also see, they can also show signs of bruxism. So what happens in bruxism? There could be that the teeth are worn out because they are in lot of stress. Psychologically, emotionally, there is a disbalance. They can have this problem. Even ADHD patients, there are a lot of ADHD patients in Australia. I don't know how, but there are too many. So you should know bruxism in youngsters. I remember there was an article published in 2023 March, around that time, on the bruxism in children, and after that we have seen questions coming up. So um, please ignore this line. Okay, so bruxism, psychological and emotional reasons could be there. Now, how do we assess in a child that they are having bruxism? It's by bite mark. Okay, so bite marks on the buccal mucosa is the only test for children to see if they are having bruxism or not. The canine primary wear is crucial and frequently linked to functional wear. Now, what happens is, what is canine guidance? Basically, if you know prosto, your canine teeth are the ones. If you move on one side, your teeth moves on the other side. What happens is your canine is guiding. That's why it's called canine guidance. Your canine guiding, it disoccludes your back teeth. That's your canine guidance. And if your canine gets attrited, if they are broken down, what happens? All the load goes on to your back teeth. Now they already have a lot of pressure on eating anything, clenching, right? And once your canine is also broken down, then they have too much of force. Then what can happen? Fractures can happen. Okay, so we can also see sometimes your canine can wear down and it can cause some issues as well. And that if canine is worn down, that's also a sign of tooth wear. Now, abnormal teeth wear or tooth...
Dr. Chi, sorry to interrupt you. I just wanted to say one more thing. Yesterday only I was seeing one of the patients who have had this sort of bruxism, which was so critically being seen, just because I could see the bite marks on the buccal mucosa as well. And also, I could see the canine was totally treated. All the interiors were treated as well. And imagine this way, he was just playing games all day long and parents were not even restricting it. So he was having all the teeth treated and he's having a lot of pressure on his jaw joints as well. So I had to refer him to the pediodontist as soon as possible.
And did you provide counseling?
Absolutely. So these concepts are really, really important, and management is the utmost importance for such cases. So glad I'm here.
Okay. Now, right. Doctor, I could see you have asked bite marks on the buccal mucosa. There will be white line. Definitely linea alba will also show whiteness on the tissue. It's basically fibrous layer. But how do you identify? You have to check. There will be on the both your buccal mucosa. One thing is that. And in fact, the patient will talk about, or you can see other symptoms as well, and then you can say other signs will tell you that the person is bruxising, and that's how there will be mention on your yes, on the occlusal level, definitely on the occlusal level, both the sides, because when you're biting, both the sides of your mouth is being used, right? So that's why you'll see on both the sides of your mouth, and that will tell you that it is basically your bite marks or a line occlusally on the occlusal where your teeth bite. At that area you'll see that line. That's how you differentiate. Okay, always in your question that will be mentioned, something should be there that will move you towards the answer that there is bruxism happening in the patient. Okay, so it will be seen on both the sides when I'm talking about your bite marks. Okay, now abnormal tooth wear, jaw muscle discomfort, fatigue or pain, jaw lock on awakening, masseter muscle hypertrophy. These are some things that we also see in the patient. I've already discussed about it, right? So that could be seen. Now, occupational sleep apnea. Then there could be restless legs. There could be rapid eye movement. These are also linked with bruxism. They coexist with that. People in this stage sometimes do bruxism might be seen in these. Okay. Now, management, how do you do? As Dr. Div did the same thing. There should be counseling. They should be explained about what basically is happening. Then only they will be able to manage it. So youngsters with orthodontic appliance, that's also one thing that is noticed is patients who are going orthodontic treatment, what happens is your orthodontist is correcting the mandible position. Generally, why apnea is happening is basically there is constriction. There is lack of space, and because of that, snoring generally happens. There is sudden loss of oxygen, and that is a problem that we see. And in those patients, bruxism is seen. So basically what happens is, if suppose people have short, or you can say constricted mandible, what can happen is sleep bruxism, sleep apnea can be seen, bruxism can be seen. So if patients are going through orthodontic procedures where there is expanding their jaw is seen, they have less chances of developing this bruxism. Okay, there is this treatment, you can remember this one. There is photobiomodulation, that's the best treatment for bruxism in youngsters, which is followed by hydroxyne therapy. Your photobiomodulation is basically putting some infrared and light on the patient's mouth. So basically from here it will be placed, and that will basically help in the treatment process. It's said because it is relieving your muscles. Okay. Then there are other therapies as well, that is kinesiotherapy, massage, infrared therapy. These are all just the names that I've given it to you, but main is photobiomodulation that you should know. That's being tested, and we know that's the best one. Okay, they generally are not going to ask what's the second best or the third best in bruxism for the treatment. You should only know photobiomodulation is the best one. There are drugs that are also used in the patient, but they will also need behavior therapy. So drug or laser therapy can be done, but your behavior therapy needs to be done as well. So they need to be explained. They might have to be sent to the GP or some specialist, so that they could be managed as well based on that. So your these are some medicines, CNS alpha and agonist, that is these ones which can be given to them, clonazepam like, to the patients with bruxism. Okay. Now management for patients. Now you see this, what do you see? These are basically your primary teeth getting affected. So this bad the situation can be. Now Dr. Divey, did you see the same type of teeth in the patient's mouth? Dr. Dev, you there? Okay, leave it. He'll tell at the end, I think. So these type of teeth can be seen, where when do we restore? The same thing that we have discussed, we restore in those cases. Okay, primary teeth, preformed metal crowns for the molar can be given. Severe erosion in permanent molars, information is lagging till yet that it is going to be beneficial or not. Okay, permanent teeth, when we talk about, anterior restoration may need regular replacement or modification. Why? Because as the child is growing, the teeth might be erupting slowly into the mouth, right? So they might need, the filling needs to be changed as well based on the time frame as the child is growing. Now posterior simple approaches such as fissure sealants or flowable composites can be placed if it is not aggressive, it is not causing sensitivity, or it is not broken down too much. Okay, severe loss, indirect restoration. Now I hope you know what does indirect word means by the lab. So metal onlays, composite onlays, CAD/CAM restorations, these can be done. Now the best will be always crowns when we are talking about your adults. Okay, here we are saying that onlays can be given, but obviously we are giving crowns at the back as well. This is a nickel chromic onlays placed onto the mandibular first molar. So these are basically onlays. There is something called inlay, onlay and crown. I hope you know the difference between all of them based on how much surface of the tooth is covered. Okay. Now Botox is for the muscles. It is for if there is too much stiffness of the muscle. Botox can be done, but I am not talking about right now in children. Okay, what I said, that will be the best therapy which I mentioned here. Okay, so photobiomodulation. Let's go by the books, what is mentioned and what you can receive in the exam. Okay, now I believe this is the last slide for today. So treatment planning consideration for implant reconstruction. So when we say if a patient is getting an implant, they have bruxism, can they get an implant or not? Yes, they can, but things need to be considered. That is increasing implant bone surface area, considering long implants where possible and wider implants in the molar region. Additional implants can be given so that the force can be dissipated. Optimizing crown to implant ratio, eliminating or minimizing the extent of cantilevers. What is cantilever? Basically, cantilever is basically a fixed FPDs. Basically, what happens is we take pressure from only one side. We are taking support from only one side of the abutments. So if this is your mouth, this is here, we are putting an implant, or if we are putting basically we are putting crowns with your adjacent teeth, by any chance if you're taking support and making like that. So cantilever is taking support only from one side. If we talk about Maryland, it is from both the sides. Okay, splinting of implants to distribute occlusal forces can be done. Metal occlusal surfaces where possible to reduce risk of porcelain fractures. We can give metal crowns on the top. There can be, in fact, we also give splints to the patient. Now, if they ask in your question that patient is getting some restoration done, no, I'm not talking about implants. I'm talking about generally, patient is getting, suppose, filling on one of the back tooth. Now, when should you give a splint? Recommended will be after that. Why? Because the occlusion will change. Okay, the biting, the things might change. So you put the filling, then you make the splint for the patient. Okay, so that's how the things go. So that's all for today. Now we have gone further. Generally it was for a 1 hour session, so I hope you all were able to get everything. One or two more things I'll just quickly tell you. So if you see some, so 1 second. I'm just trying to find out. I wrote some things that I wanted to tell you. So at the end today, I want you to go and read about proud restoration. Proud restoration. I think I've given you picture as well. Let me see if there's a proud restoration. Yeah, this is called proud restoration. Now, as the word says, proud. The restoration is proud of himself. I do in a very weird way, so I'm just going to say funny things about it. So proud restoration is like, I am very proud. I am above the surface. Why do I look above the surface? Is because the other surface has been eroded. Okay, so proud restoration sits higher, prominent than the surrounding tooth structure, and generally the restoration wears up slowly and your tooth surface wears up quickly. That's why it looks like it's been a little bit higher. Okay, this tells us about your active wear, if it is happening or not. Okay, it helps in telling how the things are progressing. So if the patient comes today, you will take pictures, intraoral pictures. You see how the restoration look like, and when the patient comes around after 6 months or 3 months or whenever they are coming, you see again how the restoration look like. If the restoration has been removed from somewhere, definitely active wear is happening. Okay. If I say about attrition, how do you know this is because of attrition? This is rubbing off. It will have sharp margins. However, when I talk about Erosion, it will have smooth margins. I'm talking about your proud restoration. Okay, it was not Tylen splint, it was Tanner splint, Tannor. Okay, that's for your mandible. The best one is Michigan, but sometimes if Michigan cannot be given, then only we give Tanner splint on the mandible. Okay, best is always Michigan. Now, in fact, in class 3, you might give Tanner as well in that. Okay. Now, so in attrition, you will see flatness on the surface, flat cusp, flat incisal surface. In erosion, you will see cup or you will see crater-like appearance. Okay. So if there is cupping seen, always remember that's erosion. Okay. With erosion, attrition can be there. So two things can combine. Okay. It's not always that only one thing is there. It can be 2-3 things combining together. Okay. And if you see there is no staining on the surface of the tooth, there's been a question. Remember, if there is stain on the tooth, there is no erosion anymore. Okay. Staining can make the restoration, basically erosion can make the restoration look proud, as well as stains will also help us in telling what basically is happening. These are the two things that you want to see in the patient. I think these were the questions that I observed in the previous exam that I wanted to discuss with you, which were important. If I say what is the most abrasive crown, that's your ceramic crown. Okay, if it is unpolished. Your zirconia is strongest. That also can cause, if it is unpolished, that can cause, that's a part of your ceramic crown that I'm talking about, that can cause wear. Okay. Now that's all for today. There was a question from from Smile. Let me see the chat now. The dental suit. Please explain. The passing percentage is low over the 4 to 5 years. And how do we ace both parts alongside by doing our jobs? Okay. If you are living in Australia, doctor, with job, we have given exams. Things happen, you have to work as well because the cost of living in Australia is very high. You have to take out the rent costs, the cost of even buying groceries and all. So you cannot live without working. Okay, so that's why we prepared Soul ADC course. The reason was because so that you can manage both your studies as well as your work together. You listen to the videos so that you are able to get all the concepts. You don't have to go and search every different areas to find out the answers or to find out the concepts about it. As I've explained here today, it's exactly like that. All the videos are that you go through, your concepts will be there, and we are there always with you to solve your questions. So the percentage, the second question, that was why the percentage has gone down. The reason for decreased percentage is because people are more concerned about memorizing things and not sitting and studying for the exam. Working and only working, not studying and just trying to go and give the exam, or only doing mocks. That's where you're lagging. If suppose in your mocks you did A, B, C, D are the options, if this comes, I'll select A. Then, my dear, you're doing absolutely wrong with yourself, and you need to understand why you selected A and why not B, C, D. Okay? So if the question says patient is taking X, Y, Z, you need to understand why, what is causing the problem, why that is causing the problem. So your basics should be clear. If your basics are clear, no one can stop you from passing. And that's why the passing rate is around 10 to 12%. Over the 4 to 5 years, it has gone gradually down, and it is still going down because people are trying to find out shortcuts to pass the exam. I don't want you to do shortcuts. I want you to take long cuts. I want you to learn the concepts so that you pass in one go instead of doing 4 or 5 times. People suffer. There are a lot of candidates who take a lot of time to clear the exam, part 1 and then part 2 as well. But if you do it right, I want you to clear it in one go only. Okay, and that's why Soul ADC is always there. You be part of Soul ADC or not, we are there. Ask us questions. You can ask for help. We will be definitely there to help you out. Not only there, we have 2 courses available. I have not shown in the slide. Don't worry about that. We are not going deep into it. It's on our website. You can go have a look. What courses do we have? We have 2 courses. Dr. Divey asked me to reduce the price. I have reduced the price for now, so you can easily access them. You can get the course. Not only that, if you are giving exam in your September, if you want the course, we have pre-recorded sessions on all the concepts. You have problem with prosto, you have problem with any subject, you can go have a look at the sessions, and you can do mocks. From tomorrow we are going to put grand mocks as well, so that you know how to solve questions where there are different subjects together. So that will be available on our portal at a very affordable price. I'm not going to say it here. You can contact us. I can let you know what we can do for you. Okay. Now, before we end, because it's been more than 1.5 hours, I would ask Dr. Div if he wants to say something right now.
Hi, Dr. Chi. I'm just in the middle of something. I might not be able to say anything at this stage. Are you able to handle the situation?
Yeah.
You know what I mean? I'm just with the little one.
Okay. Okay, that's fine. So, docs, I know there's a lot of questions that I can see on the chat. I'll recommend you please message me so that we can answer you there, or if you want, I can answer you back on there, because we are running out of time. My bub is really small. She is just turned 7 months today, so we need to feed her, take care of her as well. So I'll just end the session right now. Any doubts, let me know. Message me. I'll help you out, whatever the question is. But do not get even a single question wrong on toothware. Please make me proud by answering this question. Be a part of Soul ADC or not, please solve the questions correctly. Okay. Thank you so much for being part of this session today. Hope you enjoyed it. Hope this session helped you out a lot. And I'll be really grateful to see if you tell me if you passed the exam. Okay. Thank you so much. See you next time. We'll do more sessions later on as well. Thank you. Bye-bye.
And I just want to say, if you would like to ask us anything, you can contact us on our WhatsApp number as well. We are happy to answer you. Okay.
Yeah.
We don't want any one of you to miss out any sort of concepts before the exam even. Okay. We are not going to charge you for anything. Okay. You can ask your concepts then and there as well. Okay.
Yeah. Don't worry about anything. Just focus on your exams. Any doubts, ask us. We are there to help you out. Anything. Okay. Any nonsense question, we will help you. Comparison with respect to A and B situation. What is this? What is that? Or if you want to know about how's the life after part 1 or part 2 or whatever, for everything we are there. Just clear your exam.